All right, and now participants are coming in.
Very good. Welcome, everybody. You are coming from the waiting room into the conference. We'll give that just a minute because it looks like we have 71 people registered. So it takes a couple minutes for them to come in, and we'll get started very, very shortly. Haley, how are we looking? Our folks, we got a pretty good number of folks in?
We have 30 in so far.
Okay, we'll give it just another minute. All right, we'll go ahead and get started. Good morning, everyone. Good morning, Harnett. Good morning, Johnson. Good morning, Sampson. Good morning, Pender, Duplin, Bladen, and Brunswick County folks. We are delighted to have you with us today. I am Peg O'Connell, and I am the chair of Care for Carolina. We are a coalition of 66 organizations. We are a statewide coalition of organizations who are all pulling on the same end of the rope to find a North Carolina solution for closing the coverage gap. We welcome you all to this virtual forum about the coverage gap and the impacts that COVID has had on our state. And we hope you will find the time productive and informative. Also, it's my pleasure to thank our co-host, Comwell Health. Those of you who live in the southeastern corner of our state know them well. We were able to, 2 years ago, actually have an in-person forum, and we're hosted at the Comwell facility, which was wonderful, and it was an amazing event. So we will do our very best to welcome you from all the counties that are served by Comwell, and to make this as much fun and interesting as possible. Before we get started and I turn it over to Pam for a moment's welcome, I want to give a special shout out to Chris Van and Andrea Morales Williams. They have been troopers in getting our speakers lined up, and they have also been troopers in getting you all invited and hopefully signed up. Right now, we have 71 folks registered, so this is going to be a good forum, and we've got a nice crowd. And then I will take the privilege of the chair to give a shout out to a good friend to Care for Carolina, and that is Representative Donna White from Johnston County. She is in here someplace. And we'd also like to say hello to Chase Jordan, who's with the Sampson Independent. So thank you all for joining us. We are recording this so we can post it on the website. So if you missed something, you can go back and learn about it. All other than the speakers, everybody will be on mute during the presentations, and then at the end I'll give you a couple of instructions on how you can ask questions. You can either put them in the chat box, or there's a function for raising your hand. So we will, without any further ado, we will go ahead and get started. And Pam, I will ask you if you'd say a few words of welcome before we proceed with the program. Pam, you are on mute, I think. There you are.
I'll start again. I just want to say that we are absolutely thrilled to be hosting this event today. Thank you, Peg and Erica, for all your hard work in pulling it together. When we were meeting before, the world was a little bit different. And so to talk about closing the gap in light of our pandemic that we're living through just really is a new perspective today. So thanks everyone for joining in. Thanks for your care about your fellow man and woman and child. And I look forward to an interesting exchange and perspectives as we move through the forum.
Very good. Thank you, Pam. You are a well-known representative of the health community and a resident of Harnett County. So I want you to see that we have chosen people from a number of counties in the Southeast. So now it is my very great pleasure to introduce Jason Gray. He is a senior fellow for research and policy at the North Carolina Rural Center. And Jason is our numbers fellow. He has a way of telling us most important things in an understandable and straightforward fashion. So Jason, please, if you will take us through the numbers.
Thank you, Peg. And good morning, everyone. It's a great pleasure to be with y'all in a manner of speaking anyway. Next slide, please. So I'm going to spend about 10 minutes talking about what we know from data about the impact of the coverage gap from a chronic, that is long-term sort of perspective, and then the best available data we've got around what might the acute impact be as a result of the pandemic. So, and it's a tale of two different stories. We have pretty firm estimates on the chronic impact, economic impact of the coverage gap in North Carolina. But we have far less certainty of COVID-19 pandemic's short or long-term economic impact and what that means for Medicaid expansion. Next slide, Haley. So for the longer-term data, I'm going to be sharing data from a report that was commissioned, actually first commissioned about 4 years ago and then was updated last year, the Economic and Employment Benefits of Expanding Medicaid in North Carolina. This was a research report commissioned by the Cone Healthcare Foundation and the KP Reynolds Foundation and was carried out by the Millikan Institute School of Public Health at George Washington University. Next slide. So this analysis it's important to understand that this analysis uses an economic modeling software program commonly used in the economic development world. It's called REMI, the Regional Economic Modeling, Inc. And what that does is that it looks at, for example, if a new plant were coming to Harnett County, okay, that plant has inputs of new jobs and wages, and then that money gets spent in the economy, in the local economy and in the regional economy. The new employees are spending money at stores, the stores are then generating income for employees, and that sort of multiplies through the regional economy. So what REMI does is estimate that. It is used by a variety of North Carolina state government offices, the Congressional Budget Office, the White House Office of Economic Advisors, and it is also used by the North Carolina Economic Development Partnership, which is our main job recruiting entity for the state of North Carolina. Next slide, please. So what we know from the 2019 update, which looked at a 3-year range of data from 2019 to 2022. And here I've cut the county data by the rural center's county classification system. We have 80 rural counties in North Carolina. These are counties that have less than 250 people per square mile, 14 suburban regional city counties, and 6 core urban counties like Mecklenburg, Wake County, and New Hanover, for example. I'm a rural guy. I work for the rural center, so I'm going to focus on the rural numbers because they're the ones most important to me. In the counties, we estimate that by 2022, if expansion of some kind, whether North Carolina's own alternative or the adoption of the federal program had been adopted in 2019, we would look at an estimated impact of 11,446 jobs across rural North Carolina. This would have a broad economic impact of about $1.9 billion. That's a huge impact. There's hardly any policy program the state could advocate that would have that kind of economic impact. And in terms of local tax revenue, it would be the equivalent of $33.6 million. So that's fairly significant. Next slide, please. So let's look at three counties here: Sampson, Johnson, and Harnett. So they differ, and they tell a little bit different stories in terms of jobs because of the presence of healthcare facilities, hospitals in particular. Sampson County, an estimated 97 jobs, $21 million in economic impact, and $379,000 in local tax revenue over the 3-year period. Johnson County, 435 jobs, $107 million of economic impact. Again, this is filtered all throughout the local economy, and then $2.7 million in local tax revenue. Harnett County, sort of in between, 270 jobs, $51 million of economic impact, and $1.4 million in local tax revenue. Next slide. So when we look at this across the state, and this is by the Economic Development Partnership regions, the six regions, 7 regions across the state, and the Southeast and South, 2,000, 5,000, 2,500 jobs in the Sandhills region, 2,500 jobs in the Southeast coastal area, 11,900 here in the Triangle region, the Northern Piedmont region, and that's a reflection of the medical hospital research centers in the Triangle, Duke and UN. Next slide, please. So in terms of gross county product, broad economic impact, $458 million in the Sandhills, $500 million in the Southeast, coastal Southeast region, $2.2 billion in the Triangle, Northern Piedmont region. So the region we're talking about here kind of spans a little bit of each. So the broad economic impact is concentrated in urban areas where we have our medical presences. But for rural counties, it still matters a great deal because that money is trickling down to local healthcare providers who have been deeply wounded by the pandemic and is providing much needed economic impact in counties that many of which are still struggling. I sort of pulled the slide, but I run the numbers before by the economic tier system, and our tier 1 counties, our 40 most economically distressed counties, would have about $1 billion of economic impact from the expansion. Next slide, please. And then finally, in terms of tax revenue, you see the same thing, the concentration in the Triangle, but $6.1 million and $6.9 million in the Sandhills in the Southeast. Next slide. So the economic impact is quite significant. And now these numbers are estimates and projections, but this is a commonly used economic impact modeling program. So what I want to now shift to is to try and understand what does the acute impact look like as a result of the pandemic. Okay, so these are the July employment numbers for the state of North Carolina. The August statewide number is out, but as of a couple of days ago, the county numbers had not yet been released. So I'm using July numbers here instead of August. So from January to July, in our 80 rural counties, we had a decline in employment of 94,000 jobs. That's a 5% decline. In our 14 regional city suburban counties, again, higher population levels, bigger economic growth, a decline of 105,000 jobs, 8% decline. In our 6 urban counties, it was 155,000, again, an 8% decline with an overall decline of about 7%. Now, what is interesting to me about these numbers as a incorrigible data geek is that the impact is inverse to what it was in North Carolina from the Great Recession, which disproportionately hit rural counties, particularly rural manufacturing counties. But the pandemic, because the primary impact was in retail, hotels, and restaurants. And where are they clustered? They're clustered in our urban areas. So we've had a disproportionate impact that started in our urban counties and where the impact has been greatest, and then filtered into other economic sectors. I will say that these numbers and the statewide total for August shows pretty steady improvement from May. So we're climbing out of the hole, but we're still down, good 300,000 people employed. So that's pretty significant. Next slide, please. So another way of looking at this, the question that health policy experts are obsessed with right now is that what has the pandemic done on the number of people who are without health insurance? And this is a far harder estimate to make. A year from now, we'll have better data on this. But the challenge is that if somebody loses a job, it doesn't necessarily mean that they've lost their health insurance, because maybe, for example, if I lost my job, I could be covered on my wife's plan from her employer. So there's been some estimating being done, but it's still fairly back of the envelope. So from our August unemployment insurance claims, we know that we've got 226,986 claims that have been in the system for some time. The department estimates what of those claims are COVID-19 related, and their estimate is 143,79. So the COVID claims are 63% of the total. And again, this is a pretty significant improvement over the May and June estimates. So the question is now, of that 143,000, how many of them have lost health insurance? Again, as I said, all we've got really are educated guesses. A lot of smart people have been working on it, but the consensus is it's pretty hard to estimate. So next slide, please. I've just taken one estimate, and this estimate from the Commonwealth Fund, which is a research foundation. Their estimate is that 21% of newly employed are without coverage. So using this estimate and the COVID-related estimates for August, this would be an additional 30,000 people in the state who no longer have health insurance. I think this is a fairly reasonable, educated guess. I think it is quite certain that the numbers have grown substantially. I would be shocked if that were not the case. So the upshot is that this is the pandemic has made matters worse. So what do we do about that? Last slide, please. So my closing points for you all, then I'll hush, that Medicaid expansion, that is closing the coverage gap, has substantial benefits that advance economic competitiveness under the best of conditions. And this is especially so in our rural counties, who need not only that infusion of economic capital, but the needed stability that economic infusion would mean for the healthcare system in terms of hospitals, in terms of medical practitioners, and for general economic competitiveness. We are now competing against states that have expanded Medicaid. Virginia expanded last year, and if I were a small business looking to relocate in a rural area in particular, I think I would have this as one of my criteria. Am I in a rural area that has that support for the small businesses that gives them a competitive advantage? Then the last point, in light of the pandemic disaster, closing the coverage gap would support a substantial number of North Carolinians who find themselves without coverage. This is part of the basic safety net that people need in order to stay healthy and in order to stay financially solvent. So closing the coverage gap means a great deal for the people who would be beneficiaries of having health coverage. But I just want to close and tell you that it matters in communities, even if you already have health insurance, because it has a big community impact. And the evidence is pretty clear of that across the states that have expanded. So with that, I'll conclude and turn it back to Peg, and I look forward to any questions you might have later in the presentation. Thank you.
Thank you, Jason. We've done a couple of these forums around the state, and you get better and better each time. And we very much appreciate you pulling out some of the counties that are represented on this forum, so we can demonstrate clearly the difference that finding a solution to close the coverage gap would make. So we appreciate it very, very much. Our next speaker is someone who needs no introduction, and Pam is going to talk to us about what's happening at the community health center level and how COVID and the coverage gap are impacting the work that they do, and more importantly, the people that they serve. So Pam, please take it away.
Hey, I appreciate that. And I really do appreciate the opportunity to have a voice today, and because I feel like the people standing behind me need someone to speak out. And I appreciate again what you and Erica and all the consortium are working toward in helping close the gap. Before I forget, I want to just say and echo back on what Jason was sharing, is that rural healthcare is fragile already. We are fragile. There are great needs in rural America and in rural North Carolina, and that is where I have been my whole life, growing up in rural North Carolina in the Southeast. And during the pandemic, I really want to focus in on that. During the pandemic, if it was not for the local government and the federal government stepping in with the CARES Act and with Sampson County, Johnston County commissioners and others stepping up and helping us during this time, we would have had to restrict and shrink our services but quite a bit, actually, quite a bit. It's had quite a bit of impact on us. So having said that, we are Commonwealth Health. We're a community health center located throughout 6 counties in southeastern North Carolina: Johnston, Sampson, Bladen, Pender, Wayne, and Brunswick. Thank you. And so that's the counties we're in. And just quickly, we do medical, dental, behavioral health. We provide specialized services in infectious disease that work with our HIV/AIDS patients. We also have OB. We do WIC care, and we do case management. And one of the things we're really proud of in the last couple of years, we have been able to do Eagle Meds, which is a program that we do inside with we run our own pharmacies inside, and we provide Eagle Med, which is medication that is sent to the patients who cannot travel far to get their medicines at a more discounted price. So I'll talk about that a little bit more later and touch on that. Just to talk a little bit about FQHCs, Federally Qualified Community Health Centers is the category we fall in. And we've been that for about going on 55 years. From the time the inception of that was when we were in a very small rural country store where the community came together and said, we really need a doctor to come out here some. So fast forward today, now we've grown quite a bit, and we're serving a much larger population. Last year, around over 27,000 people walked through our doors. Now, when I say that, they say, "Ooh, that's really good." But 67% of those individuals were uninsured. 67%. So we have long finance committee meetings. Okay, the balance sheet doesn't work out that well, and we continue to see that increase. The 10 years I've been here, we were down around 50. This continues to increase, and whatever subsidies that we get from the federal government, whatever we got for a site, a practice location we opened up 50 years ago, that's the same amount of money we get today. So it is a challenge as leaders in the FQHCs in rural healthcare to how do, in our rural hospitals that are so vital and critical access hospitals, it is so vital that we look at things with the big picture. And what I want to do today is do that, but I also want to say that only 13% of our patients are on Medicaid. 13%, that's not a lot. And when you look at this expansion, you can see that we have around, I think it's 8,000, a little under 8,000 patients that would qualify for that expansion. Now, you can just already imagine 67%, 13% Medicaid, and then add that 8,000 patients, excuse me, what an impact that would have for us. It would generate over $3.5 million to come back to us in the healthcare organization. And that would help our rural hospitals, our rural health clinics, our lookalikes. It would help everybody. But most important, it will help our patients. So I want to take it real quickly from a patient perspective, if I may. I have put together my goodies that I was asked or recommended to buy on daily briefings that we had when this pandemic started. We were sending this out to our own colleagues. You need to stock up. You need to buy those things that in case you come down with COVID, you will have ready access to them and not be going out to stores and spreading. Now, this little package right here of the good stuff that I hope I never have to take with COVID, this is about $50 worth of things. This is like an emergency kit, just like if you're going to have a tornado. So this is my pandemic kit at home. Also, the other things that we all wanted to get was a lot of these products that were disinfectants and that we could keep our homes clean and, as germ-free as possible so we would not do transmission. When COVID started, we took the bandanas and we made homemade bandanas and gave them out to our patients so they would be more likely to wear a face mask. Now, the reason I bring this up is because I want you to walk in the shoes of these patients who do not make enough money to qualify. They're just over the line in North Carolina, and they don't even make enough money to get subsidies with the Affordable Care Act. So we're talking about this slice of people who we see each and every day, and I see them come through our facilities throughout the counties I mentioned. These individuals are working Americans. They are working very hard in our grocery stores, checking out. They're working in what we love in the South are Dollar Generals. We love a Dollar General. They're working in there. They're working in our short stops, our country stores. They're in our McDonald's, our fast foods. We have a lot of those in rural America. And these are individuals who have to make serious priority choices each and every day. And the choice they have to make is, what do I spend my money on today? Will it be gas? Will it be food? Will it be a new shoes for my child? What can I live without today? It's more like what they're saying. And the reason I show you this, because what was recommended, they can't afford this. They cannot, they are prioritizing. Now, I'm not saying that they didn't go out and buy some of this, but they did go to the top Dollar Tree and to the places that they could afford to get some medicines the best they could. And the reason I know that is because we talk to these patients all the time. Our care coordination department, many times, what I have found with populations that are uninsured is they will wait until they're really seriously got something going on, or they will just suffer something from high blood pressure like migraines, vision problems, possible stroke, and end up in an emergency room where the cost is so much more. But when we talk to these individuals, my providers tell me this all the time. They're not going to go to that specialist. They're not going to go out of town or anywhere, not because they do not want to get more care for their situation. They can't afford it, and they know they can't afford it, and so they say, I'm not going to go. Or my providers also tell me constantly is that we have to have the medicine, or I'm going to change this medicine to this medicine so they can afford it. And that's why Eagle Med has been so valuable for our insulin dependent patients, our diabetics. And that is one of our critical KPIs, the key performance indicators. We're really trying to work on diabetes and get our patients in maintenance with that. And what we found out was some of the insulin bills were hundreds and hundreds of dollars because they did not live near one of our pharmacies. So what we started doing was shipping it to them instead of paying $300, which they would cut their medicine in half. Can you imagine just cutting your medicine in half so you don't have to buy more? They would do things like that the best they knew how to do because they were having to prioritize their financials all the time. So having said that, we were able to bring that down and to $100 or $80 so they could afford it, and they become more compliant. We have actually seen by giving discounts and working with patients, when we can keep them out of the emergency room, when we can get them to come in, and we do a lot of phone calls to organizations, we are literally able to change clinical outcomes. But it would be so much better if they were on a benefit, Medicaid, that they would know that I can go to the doctor if I need to go to the doctor. I can get this taken care of. I don't have to wait until it is a full-blown infection and we're going, holy gracious, what is that? And rural America needs this. We need to close the gap. We need it. It's a win, 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 win. It's a win for the patients. It's a win for healthcare organizations and healthcare individuals working in rural America and in North Carolina. It is also a win, most of all, for the community, because we know if you're not having to spend all this money on just trying to not be sick or treat a sickness, then that money will be regenerated in the community. And it's a good thing. It's a win for the state of North Carolina. So I just really wanted to bring you front and center with what we see each day and our providers see. And whether it's in our dentist, that's a whole nother story I could go into, and even the children and the younger people who do not seek out dental care only as an absolute last resort. During the pandemic, we pulled over 600 teeth in this organization. And that's because our dental sites had to close down due to CDC guidelines. But for emergency cases, that's what we did. And believe it or not, we do a lot of extractions every day because they don't want to do that. They lose the tooth, pull it out. We don't have to deal with anything else, more costly expense. So I just wanted to give you a more down-to-earth, face-to-face look at the good, hard-working people that we have serving us every day and some of the struggles that they go through.
Pam, thank you. I want to shout amen. Thank you very much. You know, so many of us talk about healthcare from an academic perspective. Thank you for reminding us this is what we're all doing is about very real people. And you know, you also reminded me of something my dentist friends told me one time, that, and I don't know that many people understand this, the largest number of tooth extractions actually happen in hospital emergency rooms, because that's where they have to take you in. So, which is another whole issue. Very good. Thank you, Pam. Thank you so much. Now, it is my pleasure to introduce to you Ed Causey, who is the Sampson County Manager and a delightful fellow. And he's going to talk to us about what's happening. So we have Harnett represented, we have Sampson represented, what's going on in Sampson County and how the coverage gap and COVID has impacted his community. Ed, please tell us what is going on in Sampson.
Good morning. It is my pleasure to visit with you for a few minutes and share with you a little bit of the perspective from Sampson County. I would tell you that in a large respect, we are kind of generalists. at the administration level, because we have our experts that deals with the effects of the COVID on an individual basis. But at the same point, they depend on us to have the resources back of them as things move forward. As I make my comments, I think it might be helpful to give a little general information on Sampson County to add to your perspective. We are a large rural county. We have an agricultural-based economy of which we are very proud. We have a population of about 66,000 people. I would tell you that our financial position is very stable and sound. At the same time, I would also tell you that that stability means that we don't have the growth that we would like to have in many areas. So we have to be mindful of current expenditures, and you don't have to have much to come along that has a negative impact that shoots you down. Going back to Jason's comments earlier, he said that the projections were that we could benefit potentially $379,000 of additional revenues through through some of the expansion efforts. I would tell you that that would have a very significant impact on Sampson County and for moving forward. It may be also helpful to just give you one COVID testing data that we send out on a daily basis, and then I'm going to share with you a minute or two of where we have been and where we've come. The total number of tests that had been performed in Sampson County as of Monday was 6,534. The positive test results were 2,287. The negative test results were 4,236. We've got 1,785 people that have recovered. We've got 11 results that are pending, and we have had 27 deaths. So that sort of gives you the perspective of how the disease has directly affected us on today to the county. If we back up for just a minute and go back to March, what is interesting in a county like Sampson, we've got to be mindful. We are sort of the last wall of defense for many people on a variety of issues, whether it be issues that come up through the local health department, whether it be the Department of Social Services, whether it be the natural disasters, or whatever it may be. So we always have to be mindful of the next challenge that is out there in front of us. So when we started talking about the pandemic, I think the thing that sort of had us very concerned was trying to have an idea of how long it was going to be, what the initial impacts were going to be, and when we were going to get some relief. So we were, all of us, I think, were sort of looking into the dark. And I think from the county's perspective, what we wanted to do in meeting with our clients and our partners is we wanted to demonstrate, not only did we want to be transparent, but we also wanted to be mindful that we wanted to be very tempered and show sympathy and empathy, and also be prepared to react to a variety of issues that were coming out there. From the standpoint of how it would affect the community, we wanted to also be careful, and we were concerned early on as to whether we were not going to have to take some drastic measures internally, rather to employment and other things. As it has turned out, we're very proud of the fact we have maintained that. And so moving forward, we do believe that we have some stability. The other thing that I would share with you is very early on, we got many of the municipalities together in the county. We've got the hospital, we've got the schools, we've got the community college, and we have a variety of people that participate in a conference call every Wednesday morning to sort of make sure that we're touching base on what the conditions and what the concerns are at any given time. And we have found that to be most helpful, particularly in the early months of the pandemic. In fact, one of the things that I can share with you that I think that this group was very effective in is we recognized in a rural county like Sampson, I would say about 2 months ago, we sort of intimated from observation that a lot of our people were not as inclined to follow the recommended health practices such as wearing masks that you do in some urban areas. I was shocked. I traveled into some urban areas and hardly saw anybody without a mask, which was not necessarily what I saw everywhere in Sampson County. So we began a real public information campaign and blitz that was coordinated with everybody, and that seems to have helped a lot. So we're very proud of that partnership and that exercise. If we get down to the financial impacts on Sampson County, the biggest impact that we have had financially is we have had the loss of some county revenues. We're talking about the Expo Center. We're talking about recreation fees and those things. And believe it or not, some of those areas may not be significant by themselves, but they can be fairly significant for the county as we move forward. So as we're sitting, moving into April, and we're moving into May and moving into June, we try to be very mindful of what our receipts are going to be. We took a very conservative measure as far as budgeting was concerned, because we wanted to prepare for the unforeseen consequence that may come up. So we have had some loss of county revenues, but the good news is I'll talk about the COVID revenues in a few minutes. Interestingly enough, our sales tax revenue has basically stayed on target, and maybe even in a few instances it has been equal. Our property taxes, we basically, on our collection rate as of June 30th, we were down. We had lost. We were down about a percentage in collection, but the actual property amounts collected were equal to or a little bit greater than the previous year. So we were pleasantly surprised with the revenue position that we had for the county. Our July sales tax, which is we're moving forward after the fiscal year, our July sales tax was 1.5% lower than the previous year. Interestingly enough, our August sales tax is 17.5% ahead of the same month last year. So from a sales tax information, sales tax point of view and a revenue point of view on those fixed things that come, we seem to be stable at the moment. The other thing that I will share with you is our unemployment in August was 7.1%, and I believe that is a little bit less than the state average. So if I were describing how we are as of the end of August from a financial position, we seem to be stable to okay, and we're very proud of that. But realistically, we need to understand where this has come from, and I've got to applaud the state and federal government, because we have received a little over $3 million in revenue for a variety of sources in Sampson County through the state and through the federal government, and we believe this has helped us. I will share with you that early on, we wanted to make sure that the COVID monies that we were receiving were being utilized very effectively for health care and health prevention. And one of the things we did early on is we made the determination, I think some of you may have alluded to earlier, that we wanted to recognize our local hospital, and we also wanted to recognize our nonprofit healthcare providers in the county and make sure that we were recognizing their contributions and afford them some revenues. So I would share with you that that the money is coming from the CARES Act has been very helpful toward maintaining our financial position today. As we sit and talk about what's coming forward, the question we have as county financial managers, and probably many of you the same thing, is what is the new normal going to be? You know, is the pandemic, is the virus going to play itself out at some point in time in the very near future where we get back to what is called the normal, or are we in a position where economically, in lifestyles and everything else, are we going to have to reposition and do some things differently? For example, as you know, all of our schools are doing a variety of things in order to take care of the students. Well, what is going to happen with the schools moving forward from the standpoint of healthcare and whatever, and is that going to create additional pressure on the county? So at some point in time, I would assume that the COVID money is not, or the CARES Act money is not going to be available for additional expenditures. And what is the circumstances going to be? At this point in time, I would have to conclude my comments by saying we're pleased with the position that we're in financially based on the assistance we've received. We have no reason to believe that we cannot survive the future, but at the same time, it is still a process of anticipating what is going to happen and to be making adjustments to cover whatever the future needs are. And I do remind the group from county government standpoint, we're still in hurricane season. We've got a ways to go, and that can have a significant impact if something like that were to occur in the next few weeks. Thank you very much.
Thank you, Ed. We appreciate you sharing the perspective of what's going on in Sampson County. And hats off to you for managing through a very difficult time. And I will send prayers that no big storms come to Sampson County.
We would appreciate that.
All right, thank you very much. Our next speaker is going to be wearing two hats today. She is Dr. Marilyn Pearson. She's the health director in Johnston County at the Department of Public Health, and she is also a practicing physician. So we've asked her to talk about what is the impact of COVID and the uninsured on the work that she does in the health department, and also what she is experiencing in her own practice and what she has learned from her colleagues about how the COVID and the coverage gap are impacting the private practice of medicine in the Southeast. Dr. Pearson?
Good afternoon, everybody, and thank you for inviting me to talk. As you mentioned, I'm the health director here in Johnston County, but I'm also a family physician. So I'm going to talk a little bit about health departments and what's been happening with the health department, but also a little bit later, and I'm not going to talk that long, I am going to read some comments that were sent to me by one of our independent practices, so you can hear what has been happening with them in their practice. But I just want to start with a couple of stories and examples. Pam gave some examples too. Thank you, Pam, for that. Just so that you know, the coverage gap has been causing issues, as you mentioned, prior to the pandemic. So we've had issues there, and the pandemic, I think, has magnified those issues. So a 30-year-old without insurance and opioid addiction is depending on his parents to actually help him with his appointments and medication and trying to find some rehab. He is one of the 74 opioid overdose visits that we had in our ED from January to July of this year. And actually that number is up from 60 last year. So we are seeing an increase in opioid overdoses in our ED. We had a daycare worker who had uncontrolled hypertension, did not have insurance, was not able to get medication, and ended up losing her life because she could not get care that she needed. Those are just a couple of the stories of our neighbors, of our people here in Johnston County, and how this coverage gap is really having an effect on those who are trying to do the best that they can and getting whatever they need and the help they need. So just a little bit about health departments. You know, health departments in North Carolina are the only healthcare system in all 100 counties of our state. And although we see a large number of Medicaid clients and encounters, at least 40% of the patients we see in health departments are uninsured. And I see that in our primary care clinic, where we mainly see adults. So at least about 40% of those patients we see are uninsured. So with COVID-19, not only are our health departments now, tasked with continuing to provide care for those who don't have access, no other ways to get care, but we're also now responding to this pandemic, providing testing, case investigation, contact tracing, all those different things that we're having to do in our public health response. So this COVID has really magnified the issues that we're seeing with people and getting the coverage that they need. So for those who don't know much about Johnston County, our population is an estimated 209,000 or so about now. So it's a pretty large county. Our population is about 79% white, about 16% Black, a little over 2%, two or more races, and about 14% Hispanic. And looking at the source, depending on which source you look at, About 12% of our population live in poverty. So that's about 25,000 people. And about 14% or so are uninsured. That's about 29,000 people. So we have a large number of people that are affected by this coverage gap. Our unemployment rate in 2009 was 3.6%. Right now, it's estimated to be about 7.9%. So you can see that there's a large number of people who are being affected by this pandemic and being able to get the care that they need. Our county is pretty large and spread out. Those of you who've heard me talk before, I talk about, we have two Johnston counties. There's the western part of our county and the eastern part of our county. They're very different geographically and socioeconomically. In 2018, the median household income in our zip code 27527, which is the western part of our county, was over $80,000. In the eastern part of our county, 27526, that's the central and eastern part of our county, it's $37,000. There's a pretty wide gap of the needs that we see here in our county. And we know that there's that need, and people in our county feel that need. We do community health assessments. In our last community health assessment in 2018, we had 5 focus areas. And one of the main ones was, of course, access to care. I can tell you that access to care has been one of our focus areas for our last 3 or 4 community health assessments. So that is always an issue, always a concern for all of the people that we're trying to take care of here in our county. We develop all these action plans. We work with our community partners trying to put things in place. And despite all of that, access to care continues to be an issue, which really lends weight to the need for closing this coverage gap. And as with all of our providers in our community, our health department provides medical services, but we also provide behavioral health services. So we have psychiatrists on staff, licensed clinical social workers. And we as a health department, just as I'm sure all other providers, have seen a decrease this fiscal year in our number of encounters. We've seen that in our preventive health division, which includes our primary care, women's health, child health clinics. And we've also seen it in our behavioral health division. Surprisingly, not as much in our behavioral health division. Our show rate for that division, which of course we're doing a lot of telehealth and audio visits, has actually been pretty good. We implemented our telehealth in our medical and behavioral health areas, put screening processes in place, and continue to see some patients face-to-face as needed, particularly those, of course, with access to technology issues. Some of the things, Pam talked about, being in a rural area. A lot of our people don't have internet access. They do have a phone most of the time, so we can talk with them by phone. But we all have some obstacles that we're seeing with this pandemic. Screening people and limiting the number of people that come with them to visits is an issue. The technology, of course, is a barrier and an issue. People who are having to be isolated in quarantine, that's an issue. So we all are having lots of different challenges because of these limited resources. In addition, as a health department, as you can imagine, this pandemic has been a challenge and had a great impact, immeasurable impact on my staff. We've had in our county over 4,500 cases and 57 deaths at this point. Our peak positivity rate was over 15%. It's now down to 4.8%, thankfully. And at our health department, we've tested almost 5,000 people just through our health department. So we're continuing to respond to clusters and outbreaks. And of course, now our schools are reopening. Oh, that's going to be a joy for us. Our practice has been able to utilize CARES Act funds to assist with testing and staffing and other resources during this pandemic. But that funding really only covers testing, does not provide for sustainability of other needed services and chronic illnesses. People can't get the care that they need. So even if they go for a test, the test can be paid for, but they can't get their diabetes or their hypertension taken care of. Many of our private practices, in our county are affiliated with large systems. But we do still have a few independent practices. Some of them have had to furlough employees due to decreased patients and income. Many did not have resources to be able to safely see patients. You know, they had limitations on PPE. Many were not providing testing to their patients, and we're trying to refer patients out or trying to find people who could provide testing for them. And I can tell you that a few of them stated that getting paid for those visits, you know, Medicaid, Medicare, allowing audio and video visits made a big difference for their practices. Our health department continues to work with a lot of them, trying to provide testing and support for them. I do want to read some comments. I asked a couple of our independent providers to, you know, how this the COVID pandemic has affected them. And I'm going to read directly some comments from one of our independent practices. As if the chore to learn the science of this virus is not enough, the daily struggle to keep my solo independent medical practice open and running has been Herculean. Even as the virus bore down on us, I closed and locked my front and back doors to patients and posted signs that said, if you are sick or have a fever, do not enter. Please remain in your vehicle, drive around to the back door to be seen. Blow your horn and a staff member will come out to see you. Can you imagine? Based on what I was learning about the virus, I decided to convert my practice to telehealth, and within 48 hours, we started seeing all patients by telephone and FaceTime. These patients needed to be seen in person. And those who did were seen out my back door for a drive-through visit. To assuage fears and concerns, we joked about going back to home visits as I came into patients' homes via FaceTime and WhatsApp, and I took orders at my back door like a drive-through at McDonald's or Burger King. I called my vendors to order PPE. There was none available. So I dug out my 10-year-old N95 mask, called labs to order testing, bought 5 test kits from LabCorp, as the rep said they had a limited supply and that's all they could get me. Within 2 hours of having the test, I had a high-risk patient walking in who worked for a company that had had an outbreak. And I saw the patient perform my first test and my backdoor drive-through, and told this patient to pull their family out of work, out of school, and strictly to self-isolate. And that test was pending, but I talked with my local health department and spoke personally with the health director about concerns at the school. As I thought about my staff and their personal protection, I devised a plan to send them home, not as a layoff from work or loss of job, but in a work-home scenario. I was determined that no employee would lose their job and no patient would lose contact with me or my office. Keeping everyone employed meant paying all my employees. Unfortunately, neither the insurance companies nor the government healthcare had ever thought outside the box far enough to prepare for a national pandemic. Early on, there were not codes to send for insurance, and telehealth payments were $7 to $12 per visit. Upon learning that I could not get paid at parity, I set out on a mission to change Medicaid, Medicare, and all of the health insurance. I wrote emails, called legislators, joined WebEx groups from other rural states, and participated in calls to SEMA, Verma, and CMS advocating for payment parity for telehealth visits during this pandemic. I voiced the opinion that failure to pay for these services would force independent providers out of business, create a massive healthcare shortage during critical healthcare crisis, and increase morbidity and mortality across the nation. Furthermore, I told everyone that would listen that carving out these visits for minimal payment amounted to discrimination of poor, elderly, and the rural people in our country. There's a gap. We all need to fight to fill that gap. The financial struggle was real. And I found that my ability to see a large number of patients had diminished. As physicians, we have become telephone operators, IT specialists, cell phone app marketers in the course of this pandemic. The concern of the unknown in January gave rise to the reality of the virus and all of its ramifications by the spring. The long-term sequelae of the viral infection remains to be seen, and quite honestly keeps me up at night. As physicians, she says, Marilyn, you and I are expected to have the answers. But in this case, we have had the questions about everything from science to medical supplies and coding. And to be truthful, I believe that the camaraderie and professional alliances that have been created by our tenacity to serve and survive will be the silver lining of this pandemic. So our independent providers, from their words, have greatly been affected by this pandemic, trying to keep their offices open and trying to continue to take care of patients. The need during this pandemic has been amplified for insurance coverage. We have frontline workers, just as Pam mentioned, those who are, our childcare workers who don't have insurance. We have those who are working at fast food restaurants. Many of them are not able to afford health insurance or to pay premiums, and yet they can't stay home from work. Months into this pandemic, we had a fast food worker without insurance go to an urgent care because of symptoms. And when told about the cost, they left and they went to the ED. They knew they would not get turned away at the ED. We can do something about the coverage gap. I mean, we all need to work together to try to figure out, what is the best way to deal with this. And we all have power in our words, and power in our pens, and power in our votes. So we can do this, the way we need to do it. I do want to end with a story that shows what can be done if we provide care for those who are in the gap. I had a 56-year-old with diabetes, hypertension, depression, and anxiety, among other chronic illnesses, who had lost her insurance after divorce and was not able to afford her medication. She had utilized the ED for care and eventually came to our primary care clinic with a hemoglobin A1C of 10.8. For those of you who don't know, that tells us how well their diabetes is controlled. That's not a good number. We want that number under 6. She was referred to Project Access. That's a program here in our community in which providers donate care to uninsured adults in our county. She's gotten back on her medication. She got back on her medications. And we also referred her to our behavioral health unit. In 3 months' time, her A1C was down to 7.9. So it can be done. If we can get people covered, we can take care of the people in our community. And as a local health department, me and my colleagues, we work to fill the gaps every day of those who do not have insurance. But we can help those who are trying to get insurance if they don't have, the resources that they need. We all need to be able to provide the right care at the right time, the right place. And when someone needs care, their first question should not have to be, how much will that cost? It's up to us to try to work on this and to fix it. Thank you.
Oh, Marilyn, thank you. These people are clapping their hands for you. Thank you very, very much. And that story from your physician colleague was very, very powerful. So often we think doctors have got it made, and that based on the survey that was done recently by the folks in the Academy for Family Physicians and the Pediatric Society, we know that's not the case, especially in rural parts of North Carolina. So thank you. Thank you. Now, it's my pleasure to introduce my colleague and someone who is the engine that makes Care for Carolina work, and that is Erica Palmer-Smith. She's the Director of Care for Carolina, and she is going to talk about North Carolina's policy opportunities, and then we will open things up for questions, and I'll give you a little instruction on how we can do that without everybody talking at once. So Erica, please.
Peg, and Dr. Pearson, Pam, Ed, thank you all so much for your time today and for talking about the realities of what's going on in the region right now. What I am excited to talk to you about is that we do have an opportunity to fix much of this. And so, Haley, if you will take us to the next slide, please. We have an opportunity right now to expand quality, affordable coverage to nearly 750,000 North Carolinians. We have an opportunity to ensure that all of our frontline workers have access to timely testing and treatment for COVID-19, We have an opportunity to help stabilize the healthcare system by reducing the amount of uncompensated care. And we have an opportunity to provide a lifeline to struggling families, all with 90% of the funding provided by the federal government. There has been proposed legislation in the General Assembly that would address this issue. Last year, House Bill 655, North Carolina Healthcare for Working Families, would have closed the coverage gap in North Carolina by providing health insurance to all North Carolinians who sought out work in our state. It was a bipartisan bill. I am proud to say that Representative Donna White, who is with us here today from Johnston County, was one of the lead sponsors on that bill. Representative White, thank you so much. This bill would have brought down the 90% federal funding. It had some specific provisions in it that garnered a great deal of support, and it actually passed out of the House Health Committee with a vote of 25-6. Unfortunately, after leadership promised a vote on the bill, they failed to follow through on that promise, and we never saw a floor vote in the House for what would have been a really monumental move forward for us in North Carolina. We've also seen House Bill 1040, Healthcare for Working North Carolinians, which would expand Medicaid in North Carolina. And we've seen House Bill 1103, Access to Affordable Health Coverage for All, which would provide subsidies for folks in the coverage gap on the private marketplace. There have been numerous proposals put forward. None of these have been able to get a vote on the House floor in our legislature, unfortunately. So what we know is that right now is the time to act. And so we are asking all of you to reach out to your legislators and talk to them about pushing this through. Next slide, please. We know that North Carolina voters, by and large, support this issue. We've did a poll with the D. Stewart Group Incorporated, which is a conservative pollster in North Carolina, and the poll was conducted by Harper Polling. It was done on August 26th through 27th of this year. And what we found, Haley, next slide, please, was that 75% of North Carolina voters, 3 in 4 voters in North Carolina, support closing the coverage gap. Only 16% oppose. And then we also saw that this held up across all demographics. Next slide, please. As you can see, this was supported by North Carolina voters regardless of political party, regardless of their ideological leanings, their age, their gender, their race, or what part of the state they lived in. In fact, we saw that 64% of Republican voters, 83% of Democratic voters, and 76% of unaffiliated voters supported closing the coverage gap. A couple of other things we saw in that poll. We know that the COVID-19 has had an influence in what these numbers look like, and that's because 78% of voters expect the impacts of COVID-19, as we all know, to be long-lasting. But also really significant, and what I want to mention before we go into a larger discussion, is that a third, 34%, 1/3 of North Carolina voters right now are concerned about their own family's access to health insurance because of COVID-19. This problem is widespread. It is affecting our friends and our neighbors, and that is very evident in the polling that we've seen. I will also mention, we are coming up toward November, and we did find that 61% of those voters believe that this will be an election issue. So voters are paying attention. Thank you very much.
Thank you, Erica. All right, so where we are is we've got some questions and some shout outs to some of our panelists in the chat box. What you can do now, since all of you all are on mute, you can go to, when you wiggle your cursor, you'll see at the bottom of your Zoom screen a box that says, our little heads that say participants. You can click on that, and that will bring up everybody who is on the call. And if you would like to ask a question using your voice as opposed to your fingers to type in the chat box, you can raise your hand and ask the question that way, and Haley will unmute you. If you want to just put it in the chat box, we are happy to read it out. So, wow, you all are doing that. And Haley, if you'll keep an eye on people, and I think the folks come up as they're raising their hand, they should come up in my box. So, but first of all, I actually had a question that I wanted to just pose to both Pam and Dr. Pearson. You know, and we've been having these forums around the state, even though we're not going anyplace. And we've also talked to the folks at the free clinics. I think, you know, you are great at giving primary care, but what happens, Marilyn, I'll ask you this first, and then Pam, I'll ask you, what happens if you find a person who's got advanced cancer or even not so advanced cancer? Do you handle that in your clinics? And if not, where can they go, especially if they have no insurance?
So we partner with UNC. Many of you may not know, our health department is actually connected to a hospital here in Johnston County. And they do have a program, just as our Project Access patients actually apply for care if they are uninsured, and work through the UNC program to get the care that they need. So particularly, as I mentioned, with adults, we get them enrolled in Project Access, and Project Access actually has connections with many of our specialists, and specialists who have agreed to donate care and see some of these patients. But we also utilize our UNC Charity Care System.
Very good, very good. Pam, do you have thoughts on that question?
I do, and like Dr. Pearson, we do utilize the charity system at UNC. We have been able to form relationship or a partnership with the UNC Rex mobile unit to come down into our settings in Sampson County and Johnston County to actually do mammography. And I will tell you there, you know, when I was in the hospital system, we would complain because some women would decide, oh, I don't want to get my mammogram, I'm just going to cancel, and they wouldn't think much of it. But amazing enough, we never have any cancellations. I mean, it's almost all 100% show up, because many of these women have never had a mammogram or had one many years ago. So I'm very thankful for that program. I have to do a shout out to Vidant Health System down in Brunswick County. We have partnered with them with the mammography unit also, and the Susan G. Komen, absolutely, through that foundation. And that's what we have to work through, is foundations like that to get the care for the uninsured. Having said that, once they are diagnosed, and we have tried very hard to form relationships with surgeons locally and you know, at large tertiary care centers that would be willing to see our patients who are uninsured and do the surgery. Then, you know, for radiation chemo, that has to be either is a wait on a facility that accepts them in for that financially, and then they try to work through their fundraising to offset that as well, or charity care. But having said that, our primary care doctors do look after these patients. They are considered their primary care. We are patient-centered medical home status. That is their primary care. They come back to us. We do everything in our power to take care of them during this time of treatment and post-treatment and surgery, to make sure they're getting their needs looked after, and they're, you know, we manage their care. But that's who we take. We take care of everybody in all kinds of situations.
Very good. So, but both of you are indicating that for serious diagnoses, we are relying on the charity care network. So,
yes,
and that's oftentimes uncompensated to the bigger system. So, thank you for that. So, Ed, I will ask you a quick question, and you may not have the numbers right at your fingers, but how has COVID driven the bottom line in your health department? I know you're not the health director, but has it been better or worse?
I would tell you that the COVID monies are going to compensate us for any losses. Needless to say, with the emphasis on the COVID, we have not had the ability to provide all of the other services at the level that we would like. So, but yes, I think the COVID monies will offset any other loss of revenues.
Very good. Thank you. So we have some questions in the chat box, and I will paraphrase this first one. So why can't we get this bill passed? Christine from Moore County says, I'm blue in the face on advocating for expansion. Certainly the value input from the Rural Center and other commerce-related entities is important. So Erica, I'll sort of toss that one to you first and then see if our other panelists want to address that, if that's good. So why can't we get these bills passed?
Well, again, I think it goes back to leadership has chosen not to prioritize this issue and to move forward with a full vote on a solution. We did, again, see a bipartisan bill pass overwhelmingly through the House Health Committee. It had 26 co-sponsors, 22 of them were Republicans. It was, I guess you could call it a compromise bill, but it had things in place that certainly made it more appealing to everyone, while at the same time making sure that we could close the gap, and leadership chose not to give it a vote. As far as the reasons for why they have chosen not to give it a vote, in many ways, I wish that I could tell you what those were. I will tell you what some of the arguments that we hear are, and I'll also tell you why, in my view, they're not arguments that hold water. And the first one is the cost. We have heard consistently that there's this fear that the 90% federal funding could disappear. That is not a realistic fear. So it's been compared to the CHIP program. Well, the CHIP program, there's not a specific percentage of funding from the federal government that's set in place. There was a temporary increase, and then it went back to the normal funding levels. When it comes to the 90% federal match, it is written in legislation. So in the Affordable Care Act, it says that the federal government will cover 90% in perpetuity. They would have to actually go in, change the Affordable Care Act. Congress would have to change the Affordable Care Act, and that would have to be signed into law by the President of the United States in order for that 90% number to go away. That is not at this moment a realistic concern, but it is one that has been talked about quite a bit. The other piece that we hear quite often is that this phrase, able-bodied childbearing adults, or excuse me, able-bodied childless adults who refuse to work, and that it could not be further from the reality of the folks in the gap. You've heard the panelists here talk about who they're seeing, but I'll give you some statistics. 63% of those in the gap are working, and many of them are in fact parents. About a quarter of them are parents. So for someone to be in the coverage gap, they make less than the poverty level right now in Carolina. For a parent to be in the coverage gap, they make between about 43% and 100% of the federal poverty line in North Carolina. So what those numbers actually look like, if a single mom has one child, for her to gain access to Medicaid, she'd have to make less than $7,200 a year. She can work 40 hours a week at minimum wage and make double that, but that's not nearly enough for her to get a subsidy in the private marketplace. So we're talking about this woman working full-time, trying to take care of her child, and she is stuck in the coverage gap. Now, what does it actually cost to get private insurance in the marketplace without a subsidy? I don't know the numbers this year. Last year, I looked up the numbers. I'm actually a Sampson County native myself, and I looked up what a 30-year-old woman in Sampson County would pay to get health insurance through Blue Cross Blue Shield in the private marketplace. It would cost her $435 a month. If you're making minimum wage, you cannot afford a $435 a month payment for your health insurance, and be able to put food on the table as well. So that's the reality of the folks in the coverage gap. The folks in the coverage gap are hardworking folks. They are farmers. They are our frontline workers. They are our child care workers. They're service workers. There's the folks taking care of our parents and grandparents in the nursing homes. And these are the people that we need now.
And for especially looking at the southeastern part of the state, one of the greatest risks to a farmer is that he will get, or she will get sick and then there's no one to run the farm. I mean, and that causes an economic devastation. So it's a very relevant point here in this part of the southeastern part of our state. Our friend Chris Van, who helped pull all this together and is really just one of my favorite people down in Sampson. He's kind of stands, if he had bigger feet, he could be in Johnston, Sampson, and Harnett all at the same time. So he writes, can we speak to the fact that our federal tax dollars are being used to support Medicaid expansion in other states? It's vital to emphasize that closing the gap returns federal tax dollars back to North Carolina. Erica, would you like to take a first crack at that? And then Jason, if you don't mind, I will ask you to also follow up on that. So.
Sure. Chris, I think you said it best. Right now, we're already paying tax dollars into the federal government that other states, that Virginia, that New York, that all of these other states are using to cover their folks, while our folks are not getting that same benefit. But Jason, I think you can come at this from a better economic place.
Well, I mean, like I said, we're paying for this already in federal taxes. Okay, so so instead of our taxes going to support North Carolinians, it's going to support people in Virginia. It's going to support the program in Missouri, a Republican-led state that has recently adopted Medicaid. It is going to, we're going to go very soon. North Carolina federal tax dollars will go to support the expansion of Medicaid in Oklahoma, another Republican leadership dominated state. You know, we are in a competitive situation with everyone. Businesses against businesses, communities against communities, states versus other states. Competitive advantage is the bottom line around community economic development. You got to do what you're good at. But we are competing against other communities. And to give away our assets, to have it deployed elsewhere, when it could stay home to our benefit, doesn't strike me as being a really good deal. The motto of the state of North Carolina is first in flight. But from a policy perspective on this, our motto is first in fright. We have been afraid to make the changes that benefits our communities economically, that gives us a new competitive advantage. We have, in the 100 counties of North Carolina, we still have 2 North Carolinas. We have our growing urban areas, which are doing slam dunk growth, but we have 43 counties in North Carolina that are losing population. Most just a little bit, some a great deal. 43 counties that are losing population, and they are losing their economic competitive advantage. So it's just, to me, it's tragic that we are not tapping the resources we have available to ourselves to benefit our communities. People in rural North Carolina deserve this every bit as much as people in rural Missouri, rural Oklahoma, rural Kentucky, rural Arkansas. You know, you have to take advantage of what's there that's laying on the ground for you. And I wish we could do that.
Thank you, Jason. A couple weeks back, we did a business-focused one of these forums with business leaders from all over the eastern part of North Carolina, and we had some remarks from Dr. Waldron, who is the head of Vidant Hospital, and just a charming man. It was our first chance to actually hear him speak, and he ended his comments by saying, you know, I hate paying taxes, but I especially hate paying taxes that go to help serve people in Virginia. And then he goes, and New York. And so I think we're seeing that. We are paying for something that we're not getting. All right, any other questions? I'm checking the chat box. I don't see any hands raised. All right. Yes, from Leslie Smiley, have we looked at other Republican-led states to see how they've convinced and advocated for expansion? Erica, you want to talk a little bit about the business community's leadership in Virginia, and then we can talk just a little bit of process for anybody who's interested in that.
Sure. So the first piece is that many of those Republican-led states were drawn in by the economic advantages, similar to what Jason laid out at the start of our conversation. And so what we saw in Virginia in particular, as well as in some other places, were that the business community joined together to make this case on how this isn't just good for the health of our people, but this is really critical to the economic success of our people. And so that had a major sway in many states, like Virginia, as you mentioned. One other thing that I'll mention, so in Missouri and Oklahoma, which both closed their coverage gap this year, they did so through a voter referendum. And so while those states have consistently voted as red states, just like I showed you in the poll results earlier, this is not a partisan issue by any means, not in North Carolina and not in those states. We saw a voter referendum for passing Medicaid expansion in Missouri and Oklahoma. Now, North Carolina does not have the option to do a voter referendum. What we have the option to do is elect our representatives and call upon them to make decisions that best benefit North Carolina, which is why we are calling on them now to close the coverage gap here.
Thank you. Well, and clearly it's not a partisan issue, because one of our guests today this charge, not just this last session, but the session before, when she was a brand new freshman. So obviously her heart is with the people in Johnston County, and she wants, knowing that they're the working people who need help. Let's see. Okay, we've got a couple minutes here. Our great panelists all referenced the value of the CARES Act funding in sustaining our operations in communities during the pandemic. The Cone Health Foundation report clearly demonstrates closing the gap is akin to providing a steady stream of CARES Act. Is that from you, Jason? Who wrote that? Oh, Chris. Well done, Chris. All right. You know what? I'm going to let you do this next time, because you are much smarter than I am. So thank you very much. We are coming to the end of our time. I want to thank all our panelists. Pam, thank you. Ed, thank you very much. Marilyn, you really put a sharp end on the spear that we're going to carry. And Jason, as always, thank you for giving us the data we need to move forward. And Erica, you're just Erica. What else can I say? So unless anybody has any final comments, I'll ask any of the panelists. Anybody want to raise their hands, wave their arms? Again, to Representative White, thank you for all your support over these many years. I think, ladies and gentlemen, hearing no other comments, wait a minute, letters to the editor. Yes, thank you, right, thank you. Yes, reach out. You will get a follow-up from Erica with the slides, with the link to the recording, and with action steps that you can take. So thank you all very, very much. And we will look forward to talking to you, hopefully in person someday.
Thank you.
Take care. Higley, I think we're adjourned.